welcome from Cape, and a great big warm welcome from Cape Town. It's my great pleasure to open the 2025 chapter of the Pelvic Floor Foundation of South Africa, and I can think of no better person to open the batting, as it were, than Dr. Britta Dedekind. Dr. Britta Dedekind is a breast and thyroid surgeon at the Chris Barnard Memorial Hospital, and she will be speaking today about good breast health, how, when, why, and how and if to screen. My name is Peter de Jong, and I'm the co-host of the chapter this evening. My other host is Professor Stephen Jeffrey. Professor Stephen Jeffrey, as you would know, is a urogynecologist in private practice at the Chris Barnard Memorial Hospital. And I rate Professor Jeffrey as one of the 10 best urogynecologists in Cape Town. Now, ladies and gentlemen, Britta, I'm just going to say a few words. She's a well-respected and widely known person that collaborates with plastic surgeons and, in fact, is intimately involved with the BIGOZA, which stands for the Breast Integrated Operations in South Africa, or something to that effect. She's also chairman and established the Cape Town Breast Forum. And on the 17th of this month at 1800 hours, we're having a presentation from over here. And these will enable you to get those difficult ethics points that we also struggle to get. She also hosts the Breast and Thyroid MDT meetings. And a Breast and Thyroid MDT meeting stands for Multidisciplinary Team Meeting. There can be no better person, ladies and gentlemen, to have this afternoon than Britta Dedekind, Good Breast Health. Now, in terms of questions, she's very, very kindly allowed us to interrupt as she goes along, so we can ask questions and she can answer them timeously. We don't keep them for the end because you've always forgotten what the topic was at the end. And as I always say, the only stupid question is one that wasn't asked. Stupid questions are not actually stupid at all, because the simpler the question, the better the answer, and the more important the question. In this talk, she, being an academic, can start at the bottom and work her way down, but also go right to the top of the academic questions and can answer those too. So I'd like also to thank Nadir, who's going to be hosting and setting up. He's also doing the CPD points. All of you people that answer the CPD questionnaire that I'm going to set are able to access one CPD point, and that includes you, Britta, if you could actually answer the questions. So, ladies and gentlemen, good breast health, why, how, and when to screen. Without further waste of time, Britta Dedekind, breast surgeon. Best breast surgeon.
Thank you, Peter. So just a small correction, BIGOZA stands for Breast Interest Group of Southern Africa.
But I said, hey.
Yes, and we meet once a year, and our meeting moves across the country, and the next meeting will be in Durban in November, and it's basically designed for anyone who is interested in breast care. So it is a multidisciplinary conference, essentially. So that's also important to note. Okay, cool. So without any further ado, I was tasked with this question, and I thought I'll do a slightly different spin, because I did speak to you guys about imaging in October last year when it was Breast Cancer Awareness Month, and we went quite in depth into breast density and categorization of risk to determine the screening. And I thought it was very much based on what we do in private practice, and I thought we should just look at what we're doing in the public sector, what the actual recommendations are in our country, as opposed to looking to the rest of the world to get these answers. So, started with our National Breast Cancer Prevention and Control Policy, quite a lengthy document, but I think I've just pulled out the bits that I think are relevant to this presentation. Just want to close this thumbnail. Okay, great. So here we can see the first key area is prevention and early detection, screening, and genetic assessment. And you can see there's 4 objectives in this section. And the first objective being screening and early diagnosis. And then the second being risk assessment. They also discuss genetic services and then management of women known to have genetic susceptibility gene mutation. So our country does have a policy for this, which I think is really important. And there was a lot of time and effort put into this policy. So I do think we should give it a little bit of time in this presentation too.
Britta, who actually is responsible for this policy that you're going to show us? Is it, you just tell, is it academics? Is it people on the ground? Department of Health?
Honest, Pete, I can't tell you exactly who was involved, but I do know that Jenny Edge was involved in this. So I think Bagoza as a whole was one of the partners in creating this document with the Department of Health. But I can't tell you who all the shareholders were. Yeah. I am just struggling to change my slide.
Well, while you're doing that, just to remind people that Jenny Edge is a colleague of Britta's, and she's intimately involved at Tygerberg Hospital Breast Clinic, and one of the big hitters of breast cancer and breast cancer control and therapy in our country. Is that your next slide, Britta?
This is my next slide. So Jenny's actually moved to Johannesburg. She did her 5 years at Tygerberg and is now at the Charlotte Macquarie Hospital and part of the WITS circuit. That's very intimately involved in breast care in our country, and launched her new breast clinic at their site on Tuesday this week, because it was today. So I was invited to that, but unfortunately I couldn't attend in person.
We had already accepted our invitation prior.
So I think it's important to note that they've said that these are guidelines and that you can change and you don't necessarily have to stick to exactly what they say. And that is the whole point of a guideline. So next slide. So coming back to the key area number 1, which is prevention and early detection. And they have the objective of screening and early diagnosis. So their recommendation is that women who are over the age of 40 attending primary health clinics will have clinical breast examination. And this will be a breast examination that is done by the nurse, most likely, unless there's actually a doctor in that facility. But I think in all likelihood, this is going to be a nurse. So we need our nurses to be educated in breast examination if this is going to be helpful. And then the second standard they have is that...
So, sorry, Britta, now biannually, does that mean twice a year, or does that mean once every 2 years?
I was also wondering, because the spelling is different to the every 2 years. So I took that to be twice a year, personally.
Okay,
but I'm not 100% sure. I was also confused when I saw that.
Yeah. Okay, shall we say twice a year then?
Yeah.
Twice. Okay.
Okay. So then they've said that all the women should be given opportunistic breast education, including printed education material and taught breast self-examination. So that's quite a big ask. I think if the primary health clinics have at least got the posters up of what the concerning points are related to what you should be looking out for, that could potentially be a sign of breast cancer, that's going to be helpful. Printed material of how to do a breast examination. I don't know how helpful that is, but I think if you can teach someone to do a breast examination themselves, that is going to be more useful, because I think often when I see patients and they said they felt something and that's what's brought them to me, the way they examine their breast is actually not correct. So I think that's something that's really important. And if we can teach the patients to do a proper self-breast examination, it's going to go a long way. And then they said that we should make an awareness that is spread throughout the community and the healthcare workers, that anyone who has noticed any changes should promptly present themselves to a health facility for further assessment. And I think that's really important. In private practice, even now, not just during COVID, I have women who delay their presentation for seeking help because they're scared. And it's just so frustrating because they've known there was a problem for a long time and they just didn't go and seek any medical attention. And by the time they come to you, the disease process is more advanced and more difficult to treat. Whereas if they arrive earlier, it could be much more simple.
Britta, how good is self-examination of the breast? In other words, are people likely to find it sooner or later, or they're likely to miss it? In other words, how accurate is it to do self-examination of the breast?
So, Pete, I can't give you an exact percentage of how accurate it is, but what I like to teach my patients is the most important part is inspection, because a lot of the women that I see are quite freaked out by touching their breasts in case they feel something, or that they've noticed previously that their breast is very lumpy. So they don't know what's a normal lump versus an abnormal lump. And I think inspection at the end of the day is absolute proof that there's a problem or there isn't a problem, even at an early stage in some patients. So with knowing how their breasts look, looking at their breasts at a similar time each month, and really giving them a thorough up-down visual inspection with the arms at the side and then with the arms up at least, and knowing that a subtle change could be something dramatic that's going on within the breast. Does that
Thank
answer?
you. It does. And we've got another answer over here from Lionel. Can I just say to people that want to do questions, it's better for them to actually do put their names so we can name them. And you can put anonymous, but sometimes anonymous, it just confuses the issue. So it's better if you have your name. Lionel says, we all see young girls presenting with advanced disease way before the age of 40. What is the preferred screening for young women before the age of 40?
So, unfortunately, this policy is not talking about screening in women before the age of 40. And if you look at international guidelines, there is a movement towards risk evaluating patients in their 20s in order to determine how you will screen them going forward. And I must say, just last week, I had 4 patients, 40 or younger, diagnosed with cancer. So yeah, there's always a glitch in the system. And I think at the end of the day, if you can start with a clinical breast examination, awesome. If you can add imaging to that, even better. But I do think younger women need to be assessed when they are concerned. And I think that's also a lesson from one of my patients this week that was turned away because she was under 40 and told she doesn't need mammographic imaging yet, and then reassured falsely that her mammogram and ultrasound was fine and told there was nothing going on. And finally, her gynae referred her to me, and we knew that there was something more happening within the breast than what met the eye. So at the end of the day, a mammogram for screening, although it's not feasible in this population necessarily, is not going to be the only thing necessary if a patient is symptomatic. And if you find something clinically, or the patient has found something clinically, even if your imaging doesn't show anything, you need to persevere and get to the bottom of it.
Okay. But there's no blanket rule for when you do begin screening before the age of 40.
So only for those patients who are categorized as high risk,
Okay.
who are known with genetic mutations. The other category is patients who have a family history where if someone had cancer under the age of 50, then you start screening 10 years before the age of onset of that person. So,
Okay.
and I had that last year also, where I had a 33-year-old have her first mammogram because her mother had had cancer in her early 40s, and her gynae decided to send her for a mammogram, and she had early cancer, which would not have been detected because there wasn't nothing clinically, but there was a cancer already within her breast at that age that was detected with the mammogram. So
Okay, so it depends is the answer.
it depends on risk stratification ultimately.
Okay.
And then if we have our BRCA patients, they will start with MRIs in their 20s, and in addition to MRI, we'll add mammograms starting at 30. But that's obviously someone who's already been categorized as high risk.
Thank you.
Okay, so this is again the recommendation that we can't introduce mammographic screening unless we can screen up to 70% of the population within that group. And we don't have the resources in South Africa to do that. So that's why we don't have screening mammography in South Africa, and where the recommendation is that mammograms should be performed in symptomatic patients and identified high-risk patients. And this would be done in specialist breast units. So we have dedicated breast units at both our academic hospitals in Cape Town, and they have their policies regarding high-risk screening. And at Curtis Key, I know for a fact that they do more imaging with their high-risk patients, which is actually screening as opposed to symptomatic imaging. So it depends on where you are in the country, what is available to you once again. But just because we're talking state doesn't mean that there isn't accessibility to more specialist investigations. Okay, so this is quite interesting for me because this is their risk stratification protocol, essentially, of what they feel is low versus moderate versus high risk. And they've put alcohol and obesity as low risk. And I'll come back to this in another slide moving forward. And I want to go to what they consider high risk. So personal history of invasive breast cancer. So these patients do get screened after the diagnosis of breast cancer once they've completed their treatment. But ultimately, after a certain period of time, those patients are discharged to the community, to their local clinic for continued care, because they cannot continue surveilling those patients indefinitely within the breast cancer clinic. Lobular neoplasia, so the lobular neoplasia that we see most commonly is lobular carcinoma in situ. And this is often the patients present with microcalcifications that are screen detected. They may or may not have a family history. It's not a precursor to breast cancer. It is a high risk lesion, meaning that those patients ultimately have a much higher chance of developing breast cancer, and we try and modify their risk factors. So if they're smokers, get them to stop smoking. If they consume alcohol, try and get them to stop that. And we might even put those patients on tamoxifen. Then we've got proliferative breast disease with atypical ductal hyperplasia. So I don't know if you'll remember, but in the IBIS score, one of the questions is, have you had a biopsy with atypia? So that's what we're talking about here. So atypical ductal hyperplasia, ultimately how I like to explain it is that there's abnormal cells and more cells than there should be on the biopsy when looking at a ductal structure. And ultimately that is the precursor to DCIS, which is ductal carcinoma in situ. Then we've got therapeutic ionizing radiation for breast cancer or Hodgkin's disease. So this category I did mention in my previous talk also. These are patients who've had radiation at any stage in their life, and that puts you at a much higher risk of developing breast cancer because you've had chest wall radiation. And then they've got here specifically a BRCA1 or 2 gene mutation. So obviously you would have had to identify that with genetic testing. I can't tell you the exact policy regarding family members getting tested for these genes within state, but I can tell you that our patients who are under 40 will be offered genetic testing in the public sector, and there are other circumstances where they will also be tested. And then they said significant family history. And yet they say, for example, a first-degree family with breast cancer. And that's a difficult one, because I don't think that actually 100% puts you at a high risk. If you're looking at the patient profile that's presenting to Hertz-Ski. But yes, it's, if you put that into your IBIS risk calculator, it will ultimately put you at a high risk if it's a first-degree relative.
Sorry, Britta, just to go back to your left-hand column, I'm very perplexed as to low risk, relative risk of 1 to 1.4. Those three: alcohol consumption, first full-term pregnancy in older women, HRT, and obesity. I thought they were considerably important with smoking in increasing your risk stratification, certainly beyond 1.4, perhaps even higher than 2.
Yeah, I agree with you, Pete. So that's why I've put this here to have that discussion, because the slide that's coming up almost next is talking about modifiable risk factors. And I would say in that slide, these are much higher risk than considered here. And I can also tell you that patients on hormone replacement therapy are included in the high-risk clinic at Hertz-Ski.
That's interesting. So this is very debatable, but let's carry on in here.
Okay, cool. So this brings me to the Lancet Commission. So if any of you listened to my presentation that I gave at Christian Barnard last year, it was a summary of our Bagoza meeting, which I was a part of the local organizing committee. It was in Cape Town last year, and we had the absolute privilege of doing the Africa launch of the Lancet Commission, because I had introduced myself to the main person at a breast conference in Milan last year, and ultimately our ethics session was all around the Lancet Breast Cancer Commission. So just in summary, Lancet has these commissions where they look into the subject in greater depth, and there's multiple people that are involved in this, and they find out what are the things that are missing and what are the things that need to be addressed. But ultimately, we had a brilliant version of the actual debate that they originally had in Oxford. We had our own version, which was more a South African feel, with the international speakers also involved in that. So that brings me to this slide, which is the modifiable risk factors. And this is where we're talking about breast cancer prevention. And these are things that we can actually tell the patients about before they get breast cancer, or if they have got breast cancer, perhaps suggest that these are things that are modifiable too. And this I presented last year at Christian Barnard in October also. So here we've got obesity sitting at almost up to 28%, and then alcohol up to 16%. Physical inactivity, not breastfeeding or chest feeding, and exogenous hormone use. And under exogenous hormone use, they don't only talk about HRT, they're also talking about the combined oral contraceptive. And if you look at the little circle to the left, this is taking up a quarter of factors that are contributing to breast cancer. So this is significant. And if we can modify just if we can change just one of these aspects, we already can go a long way towards reducing the risk of developing breast cancer. And
Britta, what's chest feeding?
please. Don't you know?
Is that a silly question?
No, it's not a silly question, because I had exactly that same question today when I was going through my slides, and I looked it up, and it is actually a term used for our transgender parents so that they do not feel left out, essentially. Yes.
Sorry, could you just explain? You mean male breastfeeding?
No, I don't think it means that. I think it is a trans patient who would have breast tissue but has chosen not to. Does that make sense?
I'll have to think about it, but carry on in the meantime.
Maybe just Google it, Pete, while
Okay.
I'm talking, and then you can give us the definition. But I did look it up, and I was like, okay, this is something I should know.
I tell you what, we've got lots of people here, and I'm going to ask somebody to look it up, and Moria Stein or somebody, and to come up with the answer. What is chest feeding?
Please.
Okay, thanks.
Because one of the topics in Vigoza, we spoke about screening in our transgender individuals. So that was a lecture all on its own, which I did touch on for the summary, but I didn't think it was appropriate for today's discussion.
For general work. Okay, thank you.
Okay, so this is just a rehash of what the graph looked like before this, but I think what I wanted to take home from here was the exogenous hormone use. So they talk about the combined estrogen and progesterone hormone replacement, which increases the risk of breast cancer, and it increases over a longer duration. And then they spoke about the oral contraceptives here too. And I think that's something that I was quite amazed by, because it's not something we really get taught as surgeons as being a risk factor. Like you learn about HRT, but you don't learn about the combined oral contraceptive being a risk factor for breast cancer.
Now, you see lots of women with breast cancer. This says combined oral contraceptive has a risk factor or relative risk of 1.24. Now, anybody reading that here is 24% more breast cancer if you're on the pill. Is this your experience or not?
Pete, I must say, because of this article, I have started asking my patients the duration of usage of any hormonal contraception, and patients don't really know. I mean, I've always asked them the duration of usage of HRT, and generally they can tell me how long that is, but trying to find out how long a patient has been on a combined oral contraceptive seems to be quite difficult. And I was speaking to one of my oncology colleagues, and she was amazed that I even asked the question of the patients. I thought I was being particularly thorough in trying to assess the estrogen window for that patient. So I think my straightforward answer, Pete, is that I have no idea.
Okay. And then
Okay.
also, you don't know the pill. Is it the estrogen or the progesterone? I would think it's the progesterone, is it not? Or do you have a contrary view? If you had to guess.
To guess, I would have said it was the estrogen.
Okay. So we just don't know. We're just speculating, basically.
Yes, we are. But I think at the end of the day, for me, when I see patients, and if they tell me there's a family history of ovarian cancer and they are on the contraceptive pill, I'm like, well, please continue on the contraceptive pill, because I think ovarian cancer is going to be far worse than breast cancer. And I understand the contraceptive pill to be protective in those patients. So yeah, I think at the end of the day, you have to look at what the risks are versus the benefits and take it from there.
Thank you.
Okay. Then this slide I've just included. So while looking for what local recommendations are and what's available locally, I had a look at the cancer website. And they've got quite a cute video on how to do a self-breast examination. Can't say I agree 100% with what they describe, but I think for patients, for a simplified explanation, if they don't have someone who can teach them, it is a good guide. So that's why I've got it here. According to Cancer, they do also offer breast examination for females, not for males, at a cost. And there was something else that I was a little bit concerned about they mentioned a extra light to help with the clinical breast examination, for which they charged the extra 100 Rand. And I haven't gotten to the bottom of what that light is supposed to help achieve, or why the patient should be including that in their clinical breast examination. So that's just my 2 cents worth on the cancer website. And I think
Britta, just
yes.
before we leave the light, I know that we've had reps knocking on our door saying you've got to shine this light through the breast and it helps you. Has this ever been proven, or is this a advertising gimmick, or is this wishful thinking that a light can in any way, shape, size, or form improve the diagnosis, pickup of breast cancer? And what are you looking for in the light? Do you see us? What is your opinion?
So my thoughts is you need a well-lit room if you're going to examine breasts, okay? Because remember, I've already said I teach my patients that inspection is the first and most important part of a self-breast examination. So when you're doing a clinical breast examination, you can't do it in a dim room. You need to be able to see clearly. You're not going to see subtle skin changes or nipple retraction or a bulge or an axillary fullness if you don't have proper light. So I think normal lighting should do the job. I am not aware of any of these apparatuses with a light are going to improve your detection rate.
So you don't see any advantage. Just before we get off the hormonal question, Erwin Gertner says, in your experience, is there any increased risk of breast cancer with a long-term use of the Mirena? This was going to come up, and I'm glad we can just speak about it now. The Mirena.
Okay, so I have not come across it per se, but I can say that my oncological colleagues do not want our patients to have a Mirena if they've had a diagnosis of breast cancer. So I honestly do not believe that we can say that Mirena has caused breast cancer in patients as far as I'm aware, but I'd have to go and look at the literature regarding that.
Okay, thank you.
Okay, cool. So that brings me on to clinical breast examination. So I'm not going to go into all the details, but I think importantly, inspection start. So I start with the patient sitting on the bed. I ask them to lift both arms, and I look at both axillae. I look at the skin right across both breasts, look at the nipple. Sometimes with very large pendulous breasts, a tumor could be completely missed with the patient in the sitting position, and you might only see it once the patient lies down. But it's very nice to just be sure you've looked at all the aspects of the skin and the nipple, as well as the axilla. And then when it comes to palpation, I start with my lymph nodes. So I always ask the patients to put their hands on my shoulders, and I stand in front of them. And I start with the supraclavicular lymph nodes, then the infraclavicular lymph nodes, and then ultimately moving on to the axillary lymph nodes. If the patient's are ticklish, it helps to just push a little bit harder. And it's a very important part is the actual axillary lymph node examination, and that can often give you the first suspicion of there being greater pathology within the breast, even if you haven't visualized an abnormality. And then going on to the palpation of the breast itself. So I ask the patient to lie down with both hands behind their head. And then very important here, why I've got this image is that they're showing you that you want to palpate with the flat of your finger, not the tip of your finger. And that's one thing that patients often get wrong is palpating with the tip of their fingers. You can actually create masses that way. Whereas if you do with the flat of your finger, you're spreading out the tissue and you can feel better. So, and that also depends on personal preference. I like to go in a clockwise or anti-clockwise direction radially. So moving from the nipple outwards. Some people prefer to work from side to side. Some people prefer to go circular in circles. It really depends on what your personal preference is. As long as you've felt every aspect of the breast. And then I always focus again on the nipple areolar complex. And there I do use the tips of my fingers. And then if you are worried about the nipple, trying to see if you can lift or get behind the nipple. But I wouldn't routinely be trying to express anything from the nipple unless the patient has told me specifically that they have a spontaneous nipple discharge. But often if they do, when you're doing the palpation of the breast, you will see that discharge as it comes out. Okay, so clinical breast examination as part of screening, absolutely. It's not in all the guidelines. It's cheap and it's effective. And if you have nurses who know how to do this well, you are going to have an excellent detection rate. And I know Jenny loves using a article, and I want to say it was based in Sudan, but they basically, the pickup rate of clinical examination versus imaging, it was like 0.5 centimeters difference. So the masses that the clinical examination picked up were 0.5 centimeter bigger than the masses that the imaging picked up. Obviously, it's more difficult if you've got a large breast, dense breast tissue. But yeah, I think practice makes perfect. And the clinical examination as part of your screening is absolutely essential. And I can just tell you that over and over again, where I meet patients where they had mammograms and they were worried about something, but they were falsely reassured. Please include your clinical breast examination with your mammogram. The patients frequently cancel their appointments after having been told that their mammogram is fine. And it's so frustrating for my receptionist. And she's always phoning patients and saying, look, you've had a mammogram, has someone examine your breast, be it your GP or your gynae. You don't have to come and see Dr. Dedekind as a breast specialist, but someone needs to examine your breast and be happy that they don't feel anything. So, yes.
Britta, this question you mentioned, if a woman has large breasts, now imaging versus clinical examination, excuse me, in that instance, would imaging be much superior to clinical examination, or is it still worthwhile indulging in clinical examination in these cases? Because sometimes I feel that I really can't get to the bottom of all that breast tissue, and it's onbegonnen taak, which means very difficult to do a thorough examination under those circumstances.
So, Pete, if there is a subtle change, you're going to pick it up clinically.
Will you?
If there is a lot of breast tissue, and I see it in my patients with large breasts who've noticed their nipple was different, or noticed that their skin was different, or noticed a lump in their armpit, but left it till the point where it was so obvious. Like, I think at the end of the day, the combination of a clinical examination and the imaging is first prize. And just because the woman has large breasts, don't give up on your clinical examination. And very importantly, extend your palpation up until the clavicles. So don't stop where you think the breast ends, go all the way up.
And if a woman's got enhancements, is it still worthwhile, or do the enhancements get in the way?
No, a breast augmentation actually makes your breast examination easier because it stretches the breast tissue out over the breast augmentation. Unless they've got really small implants and very pendulous breasts where the implant's not doing much cosmetically. But generally speaking, the patient profile that I see with breast augmentation, there's very little breast tissue, and you can clearly feel when there's an abnormality. And it's also good practice to know what a implant feels like versus the breast tissue. And when the implant has an issue, it's also something you'll pick up on the clinical examination.
Okay. And the final question is, what about the skin changes? Now, you've mentioned retraction, or you didn't mention, but that's obviously the obvious one. What other skin changes can you expect that would cause a red light to flicker?
Okay, so The Pearl d'Orange is the classic
Okay.
one that we speak about, but that's obviously very advanced. Then if there is an eczematous change of the nipple, or the nipple and the areolar complex, that is very alarming. And then if there's any tethering, so it looks like something's pulling the skin in towards the breast, that is a very, very specific sign for breast cancer. You hardly ever see a benign process doing that. You can see a bulge in the skin with certain tumors, depending on their position and their size. And then saw it yesterday again, inflammatory breast cancer. It looks infected, but it's not the pattern of what an infection should look like. And the breast is usually enlarged in comparison to the opposite breast. And it has this erythematous change with almost a linear end point proximally. It's the most bizarre thing. And you just, when you see that, your heart sinks because you're like, this is not an infection, this is an inflammatory breast cancer. So inflammatory breast cancer is basically that clinical presentation where it looks like an infective process, but it is not an infection at all.
We've got the questions coming in, but here's one. During
Mhm.
pregnancy, does anything change in terms of guidelines or clinical examination because of the increased vascularity and breast tissue involvement, engorgement?
We're not going to send our patients for mammograms for screening, but I think clinical examination during pregnancy, I think please don't ignore a new lump. It's happened numerous times where patients have been falsely reassured your breast is changing because of pregnancy. Don't worry about it. You don't have to make that call. Send the patient for an ultrasound. If you feel something and the patient's unhappy, just make that call. Don't sit on it. I think with the blood distribution being more dramatic, I don't really see that with a cancer. So you kind of, your natural instinct is, well, is it symmetrical? And if it's symmetrical, it's unlikely to be pathological. And then what's also important is patients who have known fibroadenomas, these increase in size during pregnancy because of the increased hormonal stimulation. And being able to document that and for the patient to be comfortable that that's all that's going on is also really important.
Okay, we've got two more quick on the same sort of topic of imaging. Fricky Smith says, is there any place for thermography in breast cancer screening? There are a couple of clinics, non-medical clinics, that propose this and offer it to patients. I suppose that's also along the light of this illumination, along the size of this illumination. And then Kathy van der Westhuizen says, previously the radiologists seemed to routinely do ultrasound with a routine screening mammography, but lately they seem to tell women that their breasts are not soft or dense and not dense. And is it not necessary, or is it necessary to do the ultrasound? What is your opinion on thermography and ultrasound with mammography?
The thermography is something that patients seem to love, especially your alternative thought process type patient. I don't want to say that it's absolute rubbish, but it is very frustrating when patients have that and then they are falsely reassured. And I have a patient that has decided to go for alternative therapy, who's had 2 sets of thermography and been reassured, and she had an excision biopsy in another center and ultimately came to me with a diagnosis of DCIS, so ductal carcinoma in situ. and she's young, and she's got an MRI, which shows that there's extensive disease within that breast, but she chooses to follow what the thought process is regarding the thermography. So I think if we have centers offering thermography who understand that if there is anything that the patient has detected clinically, that they still seek medical attention for that, even if their thermogram is fine. I think that's okay.
Okay, thank you. And another one says, is paternal family history important as a risk factor? In other words,
Absolutely.
Yeah,
Yes.
the answer is yes. Okay, good.
Answer is yes. And paternal family history of young prostate cancer, also important. And paternal family history of ovarian cancer, also important. We get caught out by these things all the time. So the genetics, male, female, it comes from both sides. And yeah, it doesn't have to be from the female, the mom only. But now the other question, Pete, there was another question in between that I didn't answer.
It was about ultrasound plus mammography.
Okay, so I think, so we know that if we're going to combine the two, our rate of detection is going to be higher than if we do one without the other. I'm not sure why radiologists would be changing their practice to do less. That surprises me, but I do understand if they're saying that the patient doesn't have dense breast tissue and they are a density A, that they feel comfortable to leave out the ultrasound because those breasts are literally translucent. That's the perfect patient to have a mammogram. And as soon as you're B, C, or D, an ultrasound is going to be very helpful to define what's going on in that glandular tissue. Does that answer the question?
Thank you.
Okay. So I see we almost time. All right. So I'm going to.
We've got some time. Yeah.
I'm just going to skim over this because it's again something that patients bring up all the time, and it really irritates me. But it's something that we should be mindful of, is that yes, there is some radiation exposure when you have mammographic screening. So this is the European Society, and just the bottom line here is not everyone is going to have the same amount of radiation exposure. It depends on your breast size and it depends on your breast density. So it's variable, and I think that's important to know. And then I found two nice articles, which if you feel like reading, I can recommend. And this is related to radiation doses and the risk of breast screening. And the abstract here is just talking about how the different forms of breast imaging available to us have different amounts of radiation exposure. So not only is it different depending on your breast density, your breast size, it also depends on the modality that we're using. So we're using digital tomosynthesis most commonly in Cape Town now. We are not using contrast enhanced mammography, to my sadness, because it is a good modality when we have diagnostic dilemma. It's cheaper than an MRI. It has other side effects, though, is the radiation exposure. And they do have that available at Wits, which Jenny has the privilege of being able to use. So I'm quite jealous. And then ultimately, I just want to go into what the different dosages are. So this is another article, which I think explains everything very nicely, but I feel like you need at least a day and a half to process what they're talking about if you're not someone who is familiar with radiation terminology and the actual nomenclature. So this is just a nice summary of the radiation exposure in relation to other modalities. So here we can see our natural background radiation versus a mammogram versus a CT of the chest versus a spinal X-ray or a long haul flight. And there you can see at the bottom, the highest radiation exposure is a PET scan. And you won't believe how frequently patients want PET scans. Sorry, let me just close the door. There's a dog barking. Okay.
Is that your PET scan outside?
No, it's the neighbor's dog.
The neighbor's PET scan. Okay.
Yeah. Okay. So
what is a PET scan?
What is a PET scan?
PET scan.
You don't know what
like
a PET scan is? A what?
Not like a CAT scan. Not
no.
that PET. Okay.
No. So a PET scan is a form of nuclear medicine imaging, which you scan the whole body with a radionuclide to look at activity depending on what you're looking for, essentially. But it's used in certain cancers as part of the staging. It can also be used in surveillance going forward. And when I was at that conference last year, they were using it just for breast imaging, which now, knowing the value of the radiation exposure, I'm kind of flabbergasted that they were choosing to use that as opposed to MRI, which is what our preferred advanced breast imaging is. So PET scan, if you need one, chat to Peter Britta on the 14th floor, around the corner from you.
He's the nuclear physicist guy.
Yes, yes, at our hospital. So he's also part of our NDT. But generally for staging of patients, we still use CT. We are using whole body MR, no radiation with that. And then if the patient has a recurrence, the recommendations are that we need a PET as part of our staging. And we're also using that to prove oligometastatic disease to help with decision-making regarding potential curative surgery. Yeah, but that's complete aside, has nothing to do with our screening talk. Okay. So I just wanted to show you this. Very interesting for me, looking at the ranges of staging, of screening. So if you went from the young age of 25 all the way to 80, how many screening events you would have, and 56. And then going down to the minimum they have here is doing screening from 50 to 80. That would be 31 screening events. And then they've got the probable mortality per 5 to the 10. That's 100,000 patients. How many people are going to be affected by screening mammography? And that's just your DEM. So that's the most basic form of breast imaging. And then this one was quite interesting for me also, because it's looking at if you're going to do annual versus alternate years, and at what intervals and how many examinations your patient would end up having over that period of time. And again, what the mortality is per 100,000 cases. I can't quite explain to you why the 10 examinations in the 2 different age categories had different mortality implications. I'm just thinking it's because you live longer if you're younger, and therefore the radiation exposure is going to be more detrimental. Yeah, so I would be interested to know exactly why that is, but I can't give you that detail. And then this is just the last one I wanted to show you. And sorry that these are all abbreviations, but I can tell you what they all stand for. So DM is digital mammography, DBT is digital breast tomosynthesis, BCT, not breast conservation surgery, it is breast computed tomography, so it's basically a breast CT. Then CEM is contrast enhanced mammography, MBI is molecular breast imaging, and then PEM is Petrosine emission mammography. So you can see the different volumes of radiation per form of breast imaging. And there you can see the CT being the highest versus our standard mammography at the top. And this is my last slide, just to let you know that we do have a Radiology Society of South Africa, but I'm not a member of this, so it wouldn't let me access their practice guidelines, but it can tell you where all the radiologist practices are within the country. So I think, yeah, there is.
Britta, it's wonderful, wonderful. Thank you so, so much. I'm sorry we ran out of time, but I have to ask you one last question. MRI, what is the place for MRI screening of the breast in this country? If there is a place, screening.
So it's something that we are faced with quite frequently. Right now, from a medical aid point of view of buy-in, it is our patients known with a genetic mutation with an increased risk of breast cancer. We are using it more frequently in our dense breast patients after their breast cancer treatment for screening as opposed to just the mammography. We make that decision in our MDT. I literally put it to the radiologist, what are we going to screen this patient with going forward, considering their breast density, and we make that decision together as a team. Other than that, I have some patients that Discovery have somehow risk categorized so that they are entitled to screening MRI. I'm not quite sure how standardized that is. And I must say, I was quite amazed because I met a new breast cancer patient last week, and she showed me her online profile for her medical aid, and it said that she was entitled to a screening MRI, and she's under 40, and she hadn't been registered for her oncology benefit yet. And I was amazed that it was something that was part of her profile that she was allowed access to. Yeah. And that wasn't Discovery.
We got quite a few visitors here from America. Some of them stay here, and they turn up with their MRIs, and I have no idea what I'm looking at or what to do or what to say to them, because they seem to think that this is the way to go. So there is no way that an MRI screening in low-risk women is of any benefit whatsoever. Can I put that to bed?
I think if we want to be that straightforward, yeah. Yes, okay. I think that's a reasonable assessment, Pete. I think what you're saying is very true, and the people who are asking for MRIs should be able to interpret them, or at least be able to access the right team or persons to interpret them properly for you. The Americans, the whole move towards MRI is quite new, and it is related to breast density. But I think we spoke quite a bit about that with the previous talk I did last year.
Yeah, we did.
Breast density. So yeah, I think if you make that the bottom line, if you don't have dense breasts, you don't need an MRI.
Yeah.
And if you don't have any other risk factors, yeah, I think that's reasonable.
Thank you, Britta. On that note, I would like to thank you on behalf of all the people logged in this afternoon. I have sent off the CPD questions. You will be getting your CPD point if you can answer the quiz. And I love to have you again sometime later on towards the end of the year. All the very best. Thank you so much for your time and trouble. And we all look forward to seeing our delegates again, same place, same time to next week, same venue, but a different speaker, sadly. Thank you, Britta. All the very, very best and good night. Safe home.
My pleasure. Okay. Bye.
Bye.
Mhm.